everyone. Thank you so much, and thanks for the invitation to speak here. Uh, there were some technical glitches, and that's why we lost few minutes in there. But again, let's start with the show. And thank you, NASCI, and thank you, Dr. Barua, for inviting me for sharing some of the cases. Um, I'll try to be quick on the cases, but again, this is the first question. Let's do it in the case-based format as the format is here. So again, this is a PE study performed on a patient, and the question is straightforward. Like, you see contrast in the pulmonary arteries as you expect, uh, but you don't see contrast in the ascending aorta, and there is contrast in the descending aorta. Can you guess or think about a scenario that can cause that? Again, I cannot hear anyone, and
Do you think
but again, if
a
somebody
PDA?
can take that case, because I'm unable to hear, that's the problem.
Can you hear us?
Can you speak again? I changed something.
Can you hear us?
Not sure.
Sama, you can hear me, yeah?
Yes, I hear
I
you.
hear you.
Yeah, no, I can hear you now. So everything
Okay.
is off. So please, somebody can take this case.
Okay, so I'll try. So, do you think a PDA can do that?
What PDA?
Uh-huh.
Yeah, it's a good thought, and again, like PDA will be, again, we are talking about aorta to pulmonary artery shunt in routine instances, right? Or if you're thinking about Eisenmenger syndrome, again, the contrast can go from pulmonary artery to aorta in a reverse kind of a shunt pathology, but it does not look like there is anything happening. I got this candy cane view. So, but a good thought, it can cause some mixing of contrast, but again, there's no contrast whatsoever in entire aorta starting from aortic root to the arch. But a good thought. I can move ahead with the story because I withheld some of the information to make it
So,
interesting. It's a
I will think about collaterals, but I do not see any collaterals. So now we'll
yeah.
leave that with you probably. Okay.
Yeah, no, both are great comments, but again, this was a curious case for us, and again, curious from the academic standpoint. It was nothing related to, like, it was not for done for acute aortic pathology, it was done for PE study. So but when I looked at and I asked myself what is going on, so this is kind of like, this is the additional picture. Can somebody now guess? Now the answer is there. The patient has a VA ECMO there, right?
ECMO.
So again, ECMO creates a very unique situation in these patients, and especially when it is veno-arterial. As we know that the heart-lung bypass machine, VA ECMO, is commonly seen these days, and every institution does it differently. Let's try to dive into this further using the radiograph on the same patient. You can see that in our institution, the VA ECMO is done by putting a venous cannula here in the right atrium, which this patient had, and the arterial cannula kind of drains into the right axillary artery, and that's why you see skin staples and the surgical clips, right? So this is a cannula. Patient has other devices including a Swan-Ganz catheter. Let's try to paint that scenario of contrast flowing from the antecubital vein to SVC and then going into the pulmonary artery, right? So that's a technical explanation of the picture number one. You can see that this is very beautifully explaining how the contrast should be doing. Now let's see what ECMO did to this story, which explains us the contrast in the descending. So since ECMO is pulling continuously blood from the venous circulation, which is right atrium in this case, and feeding it to the machine where the oxygenation is happening, and then returning it back to the axillary artery, and again that blood flows into the descending aorta. So in that scenario, the blood coming the right route will opacify the pulmonary arteries. Since VA ECMO is indirectly bypassing both the lungs and the heart. So the patient has a bad heart and a bad lungs, then you do VA ECMO. Imagine if you take blood from a venous structure and inject into the arterial, you are actually bypassing both heart and the lung. So that was kind of a situation where the contrast has not arrived from this PE study into the aorta, but has arrived into the descending aorta through the alternate channel through the ECMO cannula. So that was something that was happening most likely in this patient that explains the absence of contrast, because The body is still pushing sluggishly the non-opacified blood in the left chambers, and there's opacified blood which is showing this mixing artifact in the descending aorta, right? And again, it's nutshell VA ECMO bypasses lungs and heart. And this publication also is a very good to look at VA ECMO. But I will say that whenever you are dealing with a ECMO cannula, look at your local kind of institutional way of doing it. Like there are two ways shown here. This is the one that I showed in our institution as well, but there are people who can do femoral artery and femoral vein as well. So it's always good to know the local practices so that you can get a snapshot of what kind of ECMO is there. But anyways, you can check into the clinical details. Similarly, VV ECMO, since you take a blood from a vein, inject it back to the vein, it will still go to the heart, right? So heart is pumping is okay, but the lungs are not doing oxygenation. So in this case, it actually bypasses only the lungs. So VV ECMO, you will have a cannula in the SVC here, a cannula again in the IVC. That's one way of doing it. But many times we have seen this single cannula with two fenestrations, inlet and outlet both, right? So again, make sure you identify these cardiac kind of supporting devices, and they can produce some weird kind of artifacts at your CT as well. And again, this paper is a good read, and now radiographics publish these cardiac device papers because as new and new devices are coming up. Any questions or comment on this case before we move on to the next one?
Wonderful case.
All right. Let-
This is a good case. So how do you report the lung findings? Because you said that the lung is not working. Yeah. So like we always get the follow-up X-rays on this kind of patient. Do you call them edema or it just collapsed lung because it is not working?
Yeah, and again, not working means oxygenation is not happening, right? So patient can have ARDS and any other kind of a possibility here. Here I called it combination of edema and atelectasis, given that there's some infiltrate here as well. Again, that's a good thing. It's very hard to say that it is all edema. Most likely it is edema because of the heart failing and the lungs also not able to oxygenate because of ARDS or some alveolar process going on. So that's how I deal with the radiograph in these situations. But to keep the thing simple, we lead with edema and then try to put in a caveat on top of it. And this is how our institution does VV ECMO cannula because they do BiFEM very frequently, right? So again, knowing your institution is very important to know the trends of ECMO cannulation and then thinking about VV versus VA, how they can make a change in your kind of interpretation and actually at the physiological level what they are introducing. All right, so next one, just changing gears here. Like, can anyone take this question and tell me? It's a single picture, but kind of like a telltale, like what it can be on the left side of the heart. Okay, so I can start on this one. So you can see that this is a SSFP image, which is a cine image, four-chamber cine image. You can see a lesion attached to the area of the fossa valis, right? You can say give or take. And there's a big lesion which is flopping back and forth through the mitral valve during the systole and diastole, right? So anything attached to fossa valis and kind of flopping like that, the first thing that comes to your mind is a myxoma, right? And again, it's not a single diagnosis. Like you cannot say, like you can argue like it can be malignancy. Thrombus generally don't get stuck there, but rarely you may have seen one thrombus doing that. But common things common generally, these require kind of cardiac surgery consult immediately if they already don't know from the echo. Usually the echo is the first step happening in these cases, and then you get MRI just to see that what might be the composition of this lesion, right? Again, cardiac masses is a broader kind of a topic. It's very hard to cover in this amount of time, but we can say that give or take, if you know the geography where the lesion is located, you can easily make your best guess and try to come up clean. Like so, the left atrium is a common location for myxoma, and myxoma is kind of the commonest primary neoplasm, and that to a benign neoplasm, right? So, and conversely, there's a saying anything on the right heart should be seen with a suspicion. It can be a malignancy like angiosarcoma loves right atrium of the right chambers, right? Again, there are multiple lesions which can be on the valvular apparatus and can be in the myocardium, and they have their own favorite locations. But again, this kind of a case actually read the textbook and kind of appears, behaves, and kind of moves like a myxoma, right? If I want to show you a companion case, not a companion, but a counterpart case on the right side of the heart, like it's kind of dancing the same way. This is a delayed contrast enhanced image, just to display like it may be heterogeneously enhancement. And again, it's very hard for moving masses to characterize moving masses when they are moving at a speed like you can see on the cine image and capturing them and calling enhancement. It was somewhat heterogeneously enhancing, as you can see here. But again, on the cine image, if somebody asks you what are the clues here and what you feel about this tumor is, it's not like a right-sided myxoma because of few things that we talked about. Like one thing is right side of the heart, you're always kind of suspicious about a cancer. Again, there's a huge pericardial effusion here, right? Again, SSFP does not do much justice in differentiating fat from fluid, but PSIR is your cheat code usually. If you see the PSIR image, most of the times you see that uh, the fluid is kind of suppressed very elegantly on the PSIR image. And again, this is a tumor or a lesion on the right side of the heart. And again, you see another aspect of the lesion being pasted on the posterior wall. What I will suggest that in the right heart, and everyone should be following these protocols, is extending their short axis cine to the atrium whenever there is a question of a atrial mass. For example, there should be cuts coming from the right atrium itself because the suspicion was a right atrial mass. And again, this is a coronal kind of a cine SSFP image. And when I was looking at this picture, I captured this slice here. And you can see there is a mass here, which is on the inferior aspect of the right atrium. And you can see IVC draining here. Anatomy can be challenging on this short axis, but if you have seen few of them, then you can easily see that the IVC drains into right atrium. So you know that which geographical location you are in. And you can see that this lesion is actually extending into the pericardial cavity, and that's what explains that it is not a garden variety benign lesion on imaging alone. And this is a delayed contrast enhancement counterpart showing the same thing, pericardial effusion, IVC draining here, and this lesion kind of extending into the pericardial cavity. And it was again a textbook or book picture case like a right atrial lesion, angiosarcoma, but here we were very confident that it will turn out to be a malignant process by the behavior that this lesion had. And again, you have to look for metastatic disease and other ancillary findings, right? Cardiac thrombus, which is the commonest cardiac mass, we can call it a cardiac mass because many of the examinations are ordered for a cardiac thrombus, right? So if you look at a cardiac thrombus, this is a traditional teaching like T1, T2, very dark lesion, like this is SSFP, which is actually not T1, T2, but a combination of both. But you can see a lesion here in the right ventricle, somewhat triangular. PSIR image, which is delayed contrast enhanced image. And you can see that the myocardium is nulled here, not the best quality image, but myocardium is nulled. That's a typical PSIR image because we set it according to the nulling time of the myocardium. And the thrombus stayed dark here. And this is a specific sequence which we generally, or which always should be done, which is a long T inversion time. 600 milliseconds is the inversion time for a thrombus. As you can see that the myocardium is grayed out here, since it's not the nulling time of the myocardium, but the thrombus stayed dark, which tells you that this is kind of a thrombus sitting in the right ventricle. But again, this is a textbook picture of a thrombus, but in real time, it's different. So let's try to apply this principle to our myxoma. Like if somebody is debating that it is a thrombus, it's not a tumor. What I usually do is I usually run the TI scout images, the same Molly sequence, on these lesions. And you can see that this is a behavior across multiple inversion times of the lesion that we already made a diagnosis based on the garden variety sequences. You can see that the myocardium has this kind of a soft tissue showing myocardium. You can see that our myxoma is kind of like has the same appearance on all the inversion times, which tells you one thing that whatever is there, it's kind of a soft tissue lesion. So if you see a soft tissue lesion and you already made your mind that it is a soft tissue lesion and you're doubly confident now it cannot be a thrombus, although there can be thrombotic components of this lesion which may behave like a thrombus. So it's a very useful tool to run a TI scout on a tumor or any indifferent, undeterminate lesion. It will actually help you be more confident in calling something thrombus versus a lesion. Again, you can apply to a thrombus. Again, the thrombus that we talked about, you can apply it on TI scout. You'll get the same kind of a answer every time, or most of the times, if you are able to catch that lesion. Again, pseudomasses, it's not based on the signal always. Sometimes the location is also very, very important, right? This posterior right atrium lesion, which actually, if you have a vibe or some other sequence, you can see that this is not a punctate lesion, but a kind of embryological stitch along the posterior right atrial wall, where the rough part of the right atrium meets the smooth part of the right atrium. Again, this is kind of a TI 600 image, first pass perfusion image. This was kind of a prominent crista terminalis, and it's kind of a book picture again. Again, a real world case where we were kind of pushed into the corner and they were asking whether it's a thrombus or a tumor for a small lesion. As most of us deal with these small lesions and they order MRI thinking that we capture everything, and then 45 minutes into the scanning, we are still struggling to get a first glimpse of a lesion, right? So, again, this is kind of a patient where the story started with echocardiogram. And again, heart murmur was there and there was a lesion. This is transthoracic echo. You can see there's a lesion centered in the right ventricular cavity on this four chamber image. And on the transesophageal echo, you can see this frond like lesion attached to the tricuspid valve leaflets. And they ordered a cardiac MRI, right? So it was very hard to find the lesion. And I can tell you, this is kind of like the image where I could see it best, not the entirety of it, but the components of it. So we saw the lesion. Forget about characterization. I was trying to think about, yeah, I found the lesion, and it was very hard for me to tell like it is attached to the tricuspid valve on that given day. Again, the tech at that time ran a TI scout just on the mid cavity as a garden variety sequence part of the protocol. And coincidentally, I thought like this one correlates very well with this lesion, and I did cross hairing and did everything. And I was pretty sure it's that lesion in the short axis. When I tried matching the TI scout behavior of this lesion with the myocardium, it was a perfect match. So I already knew that this is not a kind of a thrombus. It can be a soft tissue lesion. And I favored a tumor, although the patient was already determined to go to a surgery. And it was proven to be a tumor. And this is the clinical history. It's very interesting clinical history. Pelvic mass in a female with rounded nodules in the lungs after resection 1 year. And any takers for this thing? It's kind of like a spot image or a Aunt Minnie, like a pelvic lesion resected, and then you have rounded nodules which are benign on biopsy in the lungs. What is the diagnosis? It's METS. I see the chat, but it is a benign metastasizing leiomyoma, which actually metastasized to lungs and also metastasized to the tricuspid valve. And this is the gross specimen and the pathology of the spindle cells. And we were able to publish this case in JACC case reports. So this is a very curious case where actually the initial story is much more intense. In that publication, we never talked about the TI scout, but that was something that helped me hedge in the direction of the tumor rather than a thrombus. So I usually try to run a TI scout, which is a very fast sequence, but it's kind of a spectroscopy of any lesion when you are investigating anything with TI, multiple TI times. It usually gives you the character behind it. Again, masses are always very crazy, and again, there's no one size fits all. Every case is a unique challenge in itself. Like this patient, this was super interesting patient. The patient had a T cell lymphoma, and the patient had a PET scan. You can see that the myocardial uptake, again, that was read as a physiological uptake in the original read, and all these blue arrows are actually widespread lymphomatous involvement. It's not because the patient presented a week or so after this PET CT with a chest pain. And chest pain, they did everything they could do. They did troponins, they did coronary angiography, they did a cardiac stress testing. And again, everything turned out good. And then they said, like, let's get the cardiac MRI. Again, it's very easy to say that cardiac MRI will show everything. but it's very difficult to prove the tumor on a cardiac MRI, especially on the delayed contrast enhanced image. I just want to emphasize that the delayed contrast enhanced image is actually not a true representative of the enhancement. It is enhancement with respect to the myocardium. So if something is iso enhancing with the myocardium, that thing will appear non enhancing on the delayed contrast enhanced image. But again, I made my mind like there's something happening here. Something might be happening here. I don't know where it starts, where it ends, but it is thickened here, right? That thickening told me like there's something wrong here, which was read as a physiological uptake. I went with the older picture, the PET fusion image, and I went to the nuclear reader actually, the nuclear medicine. I said, what were you thinking when you were reporting it as a physiological uptake? He said, okay, this wall, I called it physiological uptake, but it looks very, very physiological to me. These two dots on the anterior aspect, I felt they are shine through from the lymphadenopathy. That was his words. Shine through the lymphadenopathy, so I did not call them. And this tiny did cell that you're showing me, it's too small signal to background ratio. I did not even call it. Maybe another lymphoma, lymph node or something. What we tried fancy in this case was we kind of fused the PET information with the cardiac MRI information. And long behold, you can see that all the areas of activity and arranging the window a little bit, adjusting it, you can see that every thickening that you see on MRI, even in this area where you can say it can be AV groove fat or something else going on there, lit there very perfectly. And even in the interatrial septum, there was a lymphomatous involvement. Actually, it was not a difficult diagnosis, but many times the situation is that there is so much of involvement, then you have to look at the prior imaging and sometimes come with a fancy retrospective image fusion to bring home a very common diagnosis. So MRI is very good at cardiac masses, but again, you have to be very savvy with all the imaging, trying fancy tricks, TI scout, fusion at times. I don't recommend it in every case, but it's kind of like problem solving tools that we can use for making these things. Any comment or questions I can elaborate further? All right. We survived two cases, and both cases were unique in their own cases, in their own way. Now, talking about vascular imaging or non contrast imaging, right? So, again, the commonest examination, at least in my hospital system, because of the screening program, which is unique to our system, coronary artery calcium scoring. Coronary artery calcium scoring actually uh, shows us much more than the vessels itself. There's a part of lung parenchyma above and below diaphragm, also the vessels. It's not only for calcium score, but you see a lesion here. Can anyone take this case? The lesion is pointed in the blue arrow, and what are thoughts on this thing? What it can be? Okay, I can start. So first of all, it's not normal. There's something sitting here which I have to comment on. That's a start here. And I have four options here. When I was reading this scan, I had never had these options. I made a few of them. But you can see this nodule is, so-called nodule is very weird. It's in the lingula. This lung window tells me it's not in the epicardial fat. So I will not choose the epicardial option in this by the principle of exclusion. It's not round atelectasis, not touching the pleura. There's no volume loss. There's no cometal kind of appearance. So I will not call it round atelectasis. Lung cancer, it's very weird to be a lung cancer, although it can be a lung cancer. But it has a beaded appearance. I've seen 4 or 5 patients now, given that we have scanned close to 100,000 calcium scores in last 7 8 years. So it's not common, but you can see on a non-contrast imaging a beaded appearance, and this appearance was suspicious for a vascular malformation. And again, this is the future further workup. You can see that we found a lesion, and we asked for a contrast enhanced scan, and you can see there's a vascular enhancement in the so-called nodule, and there's a feeding artery and a draining vein here, which is classical for a pulmonary AVM. Although AVM is a misnomer in the lungs, but again, it's called pulmonary AVM for all practical purposes. And again, they did a cath lab procedure, super selective kind of a appearance of this lesion, and finally did a coiled embolization. So it was a case of a pulmonary AVM detected on a calcium score examination. right? So again, please, whenever you see a nodule, especially sitting on a non-contrast examination, please look at the vessels as well as the morphology of the nodule. It may be much more than simply a lung cancer or something. So it was one of the curious cases. Again, incidental findings, it's a huge amount of things that we can see on a calcium score or any other non-contrast examination. You can see a pericardial cyst. We found a pericardial cyst, a lymphoma on the slice number one of a calcium score. Subsequently, PET CT proved it. A partially visualized breast cancer mass on a calcium score scan or avian. We published some of the examples in the paper below. So again, opportunistic detection of the lesions is very powerful uh, thing to happen, and it has been proven by multiple publications that as radiologists, as imagers, whether radiologist or a cardiologist, you cannot just concentrate on the vessels or the heart. The things outside the heart can be even more sinister and maybe more important, right? That's why we postulated a algorithmic approach in our paper as well. Like, this is how a topogram looks like. The very deceptive thing for a calcium score or any other cardiac study is the topogram shows you the both lungs and much more real state than the actually scanned area, which is this planning board, right? So you see, this is the area on the CT image that we are looking at. So if you're not looking at topogram, you may be missing out stuff. Similarly, looking at scoring is important because that's what this exam is for. And this is the scored series. Then you look at the full field of view, and then you look at above and below diaphragm. And I can tell you the examples here, like for example, the topogram. There was a cancer adenocarcinoma that we detected incidentally on the topogram image because the calcium score images did not extend to the apex. Similarly, on a small view, the breast cancer that I showed you on the last scan were also seen on the small FOV image, right? This is a very peculiar case where radiologists were just checking the calcium score, found some dead cells of calcification in the stomach, and then subsequent workup, it was a GIST, gastrointestinal stromal tumor in the stomach, incidentally detected on a calcium score. Again, peripheral cancers, you have to look at the full field of view images. So again, every picture that is acquired on a vascular study is kind of very important, and it can show you much more than the vascular thing. Again, next question. Any questions on the prior experience with the non vascular study on a non-contrast scan? All right, we'll keep moving. The next question is uh, left-sided hemodialysis catheter in a uh, corner. It's a typo here. Left-sided hemodialysis catheter. So the location of this catheter, which is kind of like you can see the double lumen here, right? The patient has other catheters, right IJ, endotracheal tube, esophageal temperature probe, enteric tube. But the question is on this catheter, which technically should follow the venous structures and should have drained on the right side of the mediastinum rather than on the left side of the mediastinum. It does not appear to follow aortic thing as well, but again, there are three options here where it can be. And again, I can also give you the CT done on this patient maybe 6 months or something back. This is a CT scan. Keeping both these pictures at your disposal, right? Not only the chest X-ray, because that highlights that whenever catheter is in the wrong position, you have to use the CT, prior CT, to determine the vascular anatomy. As you can see that a vessel lateral to the aortic arch is a unique situation in itself. And it's a venous structure here because you can see that this catheter is going into this vessel. So it can be any of these three, right? So it's basically indirect question asking you the differentials of a left-sided vessel lateral to the aortic arch. It cannot be aortic nipple or something because that it should be contiguous with the aorta. Like, there are many examples that are shown as aunt minis, like when you have X-ray and there's a pouching from the aortic nipple, that is kind of acute aortic pathology. But this is a simple catheter question. So let's try to see how to demystify these differentials, right? Uh, it can be left superior intercostal vein. It can be PAPVR, anomalous pulmonary venous return. I call it pulmonary veins have forgotten their way back home. So the pulmonary venous blood, rather than reaching the expected left ventricle, left atrium, it drains into the wrong chamber either directly or indirectly, right? So PVR is anomalous pulmonary venous return, left-sided SVC, right? So if you look at this example in specific, so it was misplaced catheter, but when we looked at this picture, and again, this is not a CT scan at the time of the catheter placement, this is a prior scan of the same patient. You can see this is the vessel which is along the lateral aspect of the aorta. It wraps around on the posterior aspect of the distal arch and kind of merges with the intercostal veins. And superiorly, it is connected to the innominate vein as well. So again, this has to be a, you can see green arrows suggest you the venous structure. It has the same curvilinear appearance of the catheter on the MIP image on the coronal picture. So it was kind of left superior intercostal vein insertion. Again, the next question is whether we can leave the catheter into that vein. The answer is no. Generally, these hemodialysis catheters are wide catheters. And the general principle is you should not leave a big catheter in a small vessel. It can be a occlusion or a thrombus created by you. That's why most of the hemodialysis catheter, they leave the tippet into the right atrium. And the central venous catheters can go up to the superior cavortal junction, although there is little bit of a flexibility in that. But using of the cross-sectional imaging to come clean on this X-ray related malpositioning is a very powerful tool, right? So vessel lateral to aortic arch, which is connected to innominate vein on the one side and to the intercostal on the other side, is kind of like a left superior intercostal vein. Every human being has that vein. But if the lateral to aortic arch vein refuses to go into the intercostal space but actually extends into the lung parenchyma, actually it is a pulmonary vein which is draining in the opposite direction, right? So it is a PAPVR. So the second differential is it can be PAPVR, but in this case, the lateral vessel to the aortic arch is hooked to the innominate vein, which is green arrow here, but the other end is in the lungs, which tells you it is the pulmonary vein which is indirectly draining into the right chamber anomalously by draining into the innominate vein, right? So this connection tells you it is a PAPVR, and then they may receive a follow-up cardiac MRI for QPQS or degree of shunt, and if the shunt is more than 1.5, that can be surgically corrected. So again, there's so much of stories beyond PAPVR as well. And the third option was left-sided SVC. When you see a lateral vessel going on the left side of the mediastinum and draining into a dilated coronary sinus, this vessel kind of a technically a left-sided SVC, or it can be duplicated SVC, right? You can see that there's a catheter on the right-sided SVC as well. So when a catheter goes on the left side of the mediastinum, if you have a cross-sectional imaging, you can easily make that distinction. Or if you're not sure, you can order a new cross-sectional imaging as well. All right, so these were the three differentials of a vessel lateral to the aortic arch. Now, coming to a little bit more novel or futuristic, or not futuristic, the present world we live in, where AI is trying to help us. Can anyone look at this case and think about something that I can give you? This is the AI output. That's how it is shown. Depending upon the vendor, you may have a different output. All right, I can walk through the images. So this patient had no trauma, nothing like that. A resident on call was reading this scan as part of a broader CT angiogram of chest, abdomen, and pelvis. And all of a sudden, we have a AI tool that flags aortic dissections. It's called aortic dissection detection tool, right? So resident on call saw this appearance. This is sagittal. This is oblique coronal in the vessel. And quickly, he or she reached out to the radiologist on call. Like AI is flagging it as a dissection. I see something floating in there in the lumen. I think it's a dissection, right? So, and then there are some debates that you can engage into, but this kind of a dissection is very hard to see, which is strictly on the inner surface of the aortic arch or proximal descending thoracic aorta, with no trauma history, no hypertension history, nothing it was done for. It was done for something in the belly, even. So, how can a dissection appear with the patient being asymptomatic, which is kind of not the thing? Intimal thrombus is another thing, like some thrombus attached here and then dancing here. Again, it's kind of like has a fuzzy border. It does not look like a concrete discrete thrombus or something. Sarcoma on the same line, if you are convinced that this is a discrete lesion, you can say thrombus or sarcoma, but a very simplistic description can be Dean effect, which is actually a fancy name for the flow related artifact, right? So again, these flow artifacts notoriously happen along the inner curvature or the inner side of the aortic lumen, right? So again, AI thought that this is a kind of like a flap, which it looks like, but it is very fuzzy, and human beings can see that it's a mixing of a contrast with unopacified blood, right? And there have been papers published which tells you that how the turbulence happens along the inner border where the velocity of the blood is slower than the outer border, right? And so the laminar flow is disturbed in this location. So if the patient has cardiovascular, some other things going on, low cardiac output, and some other predisposing phase of the study, this is a common site for that flow related artifact also in the D. This patient had no dissection. It was a flow artifact. Talking about AI, I'm a big proponent of AI, but sometimes we see some things very easily. We see that there is a graft here which is extending from the ascending to the descending. And AI is telling me there's a dissection happening here. I'm not going to buy that because I know that and there's no dissection flap. It's kind of the lower end of the stent graft, which is picked up by the AI as a dissection. Again, AI helps us a lot. It's good, like in another vessel. You see a filling defect in the pulmonary artery with all the artifacts from the spinal hardware. AI found my PE, and I was so happy. And again, that's a true positive AI, the value of AI. But again, many times, even when your eyes tell you there is a filling defect, you can see that right lower lobe branching point, segmental subsegment, it's a very discrete thrombus. I will call it thrombus on any day. And AI stamped on it as well, like, hey, this is a PE. Maybe it should be actionable or not, that's a separate thing. But this patient had a three-phase scan for some other reason, and that few seconds later, my filling defect disappeared. So this means that this was also a flow related artifact. And again, lot has been written about flow relating artifacts. Many times, if you are in doubt, you can get a repeat study if it is as distinct as this one. But again, many times there are clues to it. Like this is the front page of the last year's radiographic paper published. It's amazing paper for looking at flow related artifacts. And these are the two examples that I showed you. One in the pulmonary artery, like similar examples. These are their own examples. You can see the same flow related artifacts on the inner aspect of the proximal descending aorta, as well as you can see that there is flow artifact happening because of the bifurcation and the complex flow. So this is a must read paper for somebody who wants to know more about the flow related artifacts. Again, not to belittle the real sinister findings, like the closest that you can get to this artifact, that's why the clinical context is very important, motor vehicular collision. So this is a separate case where we found something in this region where you can see the ductal calcification. This tiny dead cell is kind of, most of the human beings have that calcification, but there is more to that. It's not wispy. It's actually chunky hypodensity, which is in the lumen and kind of like pouting here on the CT angiogram, right? And again, there are lacerations in the lung, which tells you the patient is hurt in a motor vehicular accident. And this is a site of maximum shearing forces. And whenever you see a trauma patient, this is the location or the one of the two most commonest location, the root and the point where the ligamentum arteriosum in the adult life is connected. So it has all the red flags here, right? And it is kind of like very minuscule, but still a injury, right? And that's why it is called minimal aortic injury, right? So it's very hard to detect, not hard to detect if you know about it. The clinical context, imaging appearance, location, all tells us minimal aortic injury. And there are classifications for that. If you see a flap only, which is the most subtle aspect of it, that is type A, B is bigger flap, and type C is with the adherent thrombus. So it was indeed a minimal aortic injury, a type C minimal aortic injury. So not to get fooled with the artifacts, there are some sinister things sitting there, right? All right, so continuing with the same theme of trauma, this another kind of a interesting case. happened in our ED as well, right? The patient, 39-year-old young patient coming to ED, got a pan CT chest or angiogram of chest, abdomen, and pelvis. If you want to see something or shout out, these are the axial images, and this is the oblique coronal image, and you can see the rib fracture, which tells you the trauma was very severe. The left lung is totally filled with lacerations, consolidations. So which option will you pick here, given these two images? Again, we can continue. Number one is always a distractor in these cases, even if you are in the ABR or any other exam, because I want you to take a bite at this outpouching, which may be looking as aneurysm, but this picture empower you. How many pseudoaneurysms you have seen which have a vessel coming out from their summit, which is a very typical appearance for a normal variant. I already taught you minimal aortic injury. It does not look like a minimal aortic injury. It's much more than minimal because something is going outside the aortic lumen, right? PAU, penetrating atherosclerotic ulcer in a 39-year-old where there is no atherosclerosis, so atherosclerosis is not there. How can a PAU happen in that, right? So basically, it was a debate between these two. And whenever you see these outpouching, especially medially arising from the upper descending aorta, try to see that if this outpouching ends into a vessel or region. So it has a name to it, infundibulum of the whichever vessel it is. In this case, it was right third intercostal artery. So basically, branches arising from aorta can be a red herring, and they may push you into a different direction. Look at ancillary signs. There's no hematoma, there's nothing happening. Although everything on the left side is broken, that should not bring you into making this diagnosis of a pseudoaneurysm, right? And again, the similar pictures, the same explanations. The left lung is fault, but the aorta is totally fine. So no vascular surgery consult required here. The aorta is fine. Again, closing the kind of like completing the topic on PAU, since one of the option was PAU. You can see rip roaring atherosclerosis. Then there's the pouting stuff going on there. Again, you can debate between a diverticulum from a ductus or a PAU. Again, if this is the first scan the patient is getting, and the clinical symptom says acute chest pain, I will not be brave enough to say like, oh, it is certified PAU. And again, you should always look for PAU and look for prior imaging for stability of this finding, right? In other words, if you see this on the first scan and the clinical profile is like that, you should call to the vascular surgery or the requesting physician that I cannot make a determination whether it's a pseudoaneurysm happening or a PAU. In this case, it was a PAU, right? And again, the guidelines mention measuring PAU in different formats. But again, the basic thing is like if even if there is a PAU, the main criteria for repair is symptomatic patient. If you say that a PAU is there and the patient has a chest pain, vascular surgery may decide to treat it. But again, there are some different parameters that they try to use. One of them that you have to report for sure, not go crazy with all the measurements, is growth of a PAU. Because the growth of PAU is a very important factor to keep in mind whenever you're dealing with a penetrating aortic ulcer. If it is kind of like growing, that is a different kind of a signal. If it is symptomatic, that's a different signal for the surgery team as well. But I usually report the depth and the diameter because the guidelines are based on that. Closing the final case, a companion case, like again, when you have this kind of outpouching with so much of hemorrhage in the mediastinum, and you can see it on a reformation as well, right? So that time you should not have any doubt calling it pseudoaneurysm. And when you look at the coronal image, there's a big pool of contrast here, even on this arterial phase study, that tells you this is a classical pseudoaneurysm in a patient which is complaining and presenting to ED with chest pain, sudden onset chest pain, hypertensive patient, and now hypotensive. And then this kind of a situation should never be thought of as any other normal variant or kind of like any penetrating atherosclerotic ulcer. It is much more than that. And plus, there is no atherosclerosis where the ulcer is happening. So it is kind of a aortic transection, pseudoaneurysm. You can use those kind of words for this blunt aortic injury. So if you look at the another patient, the final case in this series is I think this is the same patient on the last one. So they decide to emergently treat it. They did a T-VAR here. You can see that these are the struts of the stent graft, which is covering the subclavian and kind of left common carotid arteries as well. So when you are reading a post-op scan, always look carefully for these struts. Are they extending into the branch vessels? And in this case, it was extending into the subclavian artery. It's very difficult to make that call, but many times that can happen. So it's always good to mention that, oh, the subclavian artery is at fault. And many times there may be carotid to subclavian bypass. In this case, that was not the case even. So we raised that flag, and it was found that it is kind of extending into the subclavian artery, and the patient had subsequent carotid to left subclavian artery bypass. Uh, Companion case, again, pseudoaneurysm in the same location. This is angiographic images. They did an expandable stent here to control this pseudoaneurysm. 2 weeks later, the patient again had an episode, and you can see that outside the stent there is something happening. The streak artifacts can throw you off. It's not a collection. There was some contrast leaking into it, or it was kind of technically an endoleak. This is a beautiful 3D volume rendered image. Back to the cath lab and kind of restenting stent within a stent. Again, whenever you have a stent in place, your report has to mention that there is no leak happening, and there are called endo leaks, right? So endo leak is totally different topic, but again, in short, there are 5 types of endo leaks, and most of the times, if you know the first three, most of the times you see a type 2 leak where a branch vessel is draining into that excluded sac. But in our case, it was kind of going through the substance of the graft, so it was a type 3 endoleak, which is kind of contrast extravasation through the middle portion of the graft, or a defect in the stent graft, right? So which has to be repaired. Again, it can be as subtle as like the excluded sac keeps on dilating, so then it can be type 5 as well. Uh, I think we should stop here because it is 1:54, and I want to answer any questions if anyone has that.
Wonderful case. Thank you for sharing those cases.
I have a quick question for that pseudo dissection that you saw. So, what do you guys usually do? Just call it pseudo dissection or repeat the study?
Yeah, that's a great question. And again, it depends upon the confidence of the person who's reading it. And again, I asked the same thing to the on-call radiologist, the ED person. He said, like, it's very wispy, and I could not put my head on it, and there's no clinical suspicions for that. And again, we called it confidently a flow artifact on that one. But there have been instances where there's an element of doubt. The clinical history is in that direction. Talking to the vascular surgery is the best way to go forward with it. And most of the times, or many times, you may have to do a repeat scan as well to convince everyone on the team.
I have a question about the retrospective fit and an MR. Is how this was done? Is it like you pulled up the software of the nuclear team?
So, yeah. Again, my background is I've done a fellowship in nuclear medicine as well. I still have access to the fusion softwares, which are very easy to use once you know about it. You just have to upload 2 series and then try to fuse the images based on the anatomy. And actually, it is kind of like a multi-step process, but I do it for my own understanding. But it has been proven to be helpful in the problem cases, especially educating, not even for myself, but educating the clinical teams and presenting to their fellows like, hey, cardiac MRI can show you the tumor, but again, it is a combination information. But again, that was done offline on a third party workstation and using a nuclear medicine software. I think with that, I really thank you for your patient hearing, and thank you again for inviting me and sharing these cases. I'm not sure uh, how curious those cases were, but again, I got curious when I look at these cases, and every case teaches us something. So thank you for your patient hearing.
Greatly appreciate you hosting this for us, Dr. Gupta.
You're welcome. Thank you so
Yes,
much.
thank you so much.
Thank you so much.